So anyway, so we're going to talk a little bit, get some new things and some old things. We're going to talk about main issues around lifting and strenuous work and its, excuse me, and its association with preterm gestation, preterm delivery, and low birth weight, and newer information, newer research has confirmed some of the older findings or previous findings. Then a little bit about newer hazardous jobs along with that are the ones that are generally related to things like lifting and hard physical work, particularly, or even so in an economy that's moved into service from manufacturing and labor, and then cover the legal framework for pregnancy protection in the workplace. And this is where much of the newer stuff will show up, because that's involved with the Pregnant Workers Fairness Act, which came online in 2023. So that's about a year and a half, 2 years old. For that. So anyway, and this is kind of where we sit in it there, the New Yorker cartoon of this is from a long time back, one of those shadowy figures who inhabit the mysterious twilight where the medical and legal professions meet, and many of us can relate to that there. We'll talk about briefly occupational exposures, and then I'll show you some slides of an actual workplace assessment. So pregnancy exposures and reproduction and pregnancy get a lot harder than, for example, those exposures that you can quantify and pretty much assume that the exposure is going to continue. So if there are skin hazards or pulmonary hazards, you can pretty much assume that everybody's going to be exposed at the levels that you're measuring, or that you've quantified them reasonably accurately. For reproduction and particularly pregnancy, the timing of the exposure is critical, and then there are some toxicants or exposures that become more deleterious in pregnancy than they would have been outside of pregnancy. We've got limited data on reproductive outcomes, so much of that comes from animal toxicology and limited human epidemiology, much less than, for example, other organ systems or exposures. The other problem is if you try to look up PELs or TLVs related to pregnancy, you generally find that those are limited to health effects in guys who are constantly exposed, and it doesn't have very much to do with reproductive hazards, and there's only a bare few that have any kind of TLV, and forget about PELs because those are written in stone from the time they come from OSHA, and they haven't paid much attention to pregnant workers. Always remind people that maternal and fetal physiology change during pregnancy, so that increased toxicity or changes in toxicity are going to occur at various times, and sometimes as a continuum, sometimes rather abruptly in pregnancy. My main example, which I won't be showing today, but you might have heard me talk about, is lead, which gets released from bone because in the second and third trimester, the fetal skeleton is avid for calcium. And where does that calcium come from? It comes from osteoclastic activity in bone, which gets revved up during the pregnancy, so that if mom has been exposed to lead for a long time, then the bone becomes a great storage depot and starts to release lead along with the release of calcium from bone. The other one that might be sort of closer to your main work is wearing respirators. So remember that at the second trimester, mid-second trimester and upward, the gravid uterus starts to press on the diaphragm, and so FVC, or vital capacity in general, decreases. Minute volume ventilation increases to compensate for that there, and you may get over or higher exposures to airborne toxicants than you would usually. And at the same time, particularly with things like negative pressure respirators, you're going to have some trouble inhaling with them a little bit more there. It may or may not matter. It depends upon the situation. So that's the challenge in looking at it there. And then the other thing to remember is that, as we always say in OcMed, work is good for you. So pregnancy outcomes are generally better if you take sort of all broad brush working mothers versus non-work. You end up with a kind of healthy worker effect for pregnancy and pregnancy outcomes. And it's not necessarily clear, it's probably 2 or 3 or more of these reasons why you get benefits. So you're working, you get health insurance, you get to see the obstetrician sooner, you get better care, you get better care sooner, and your obstacles to care are much less. Workplace as social support and structure, the same reason why we treat back pain by trying to get people back to work. Maybe a healthy worker effect, less healthy mothers get put off work or aren't working, and it may be a marker for other positive attributes like higher SES, that generally better neighborhoods, better better lifestyles that go along with working. But then the problem is that within workers, there's a sort of a subset that are riskier occupations. And again, we have tended to think of those as manufacturing jobs, laboratory jobs, those types of things. Most of those generally, again, either take place in larger workplaces that now have better controls than they used to, and otherwise have been controlled, and unfortunately to some extent it may have been offshored to other places, things like particularly lead exposure in battery work. So anesthetic gases are better controlled here. There's an association with spontaneous abortion, but most of that is controlled through scavenging systems and the use of other anesthetics, which might be less, less toxic there. The problem comes in the small shop. So you go to the dentist's office and they're giving nitrous oxide, they give it through a cannula, and the dentist or the dental assistant becomes exposed to nitrous, and that's the one that's generally associated with spontaneous abortion. Our main concerns now are in things like high physical demand jobs, and so that has always included nursing personnel. I'll show you some slides of associations with heavy lifting. Food service workers have high physical demands, and fundamentally many small shops, they don't have any health and safety oversight. They generally are somewhat less interested in ponying up for materials, source ventilation and the like that can go into controlling chemical exposures and the like. And if you sort of cast an eye at this list, there is many, particularly high physical demand food service workers and the nail salon industries and the like. These are people who also have, they're not being paid well, they don't necessarily have insurance, low socioeconomic status in general, return to poor neighborhoods where the risks to pregnancy are probably additive to those that they're seeing in work. So there's a lot of crossover in trying to sort out how those happen there. So look at ergonomic hazards in particular, because these are the ones you're most likely to see. So physically demanding work, heavier repetitive lifting is associated. This was a meta-analysis of now pushing about 25 years ago that was in obstetrics and gynecology. It was the first paper to meta-analyze a lot of work that had been going on in the 80s and 90s with somewhat variable results there. But so the risk of sort of constant physical demanding work for gestational age, i.e. low birth weight, there's about a 30 to 40% increase in SGA birth, and for preterm delivery, a little bit less, but still about 20%-ish range and the odds of low birth weight compared to those not working there. less stable odds ratio sort of broke down some of those elements of physically demanding work into prolonged standing and shift and night work all have about the same risk for preterm delivery, and high cumulative work fatigue, which is essentially doing all of those things that you see at the top of the slide, had a higher odds ratio and higher risk, although a little less stable than that. There are no, I always tell the residents that we're looking at there's no association with long work hours in the absence of increased physical demands. So for residents, unless they have high physical demands, or friends of yours who graduated from law school and are working insane hours downtown, there's no association with that there. So the Danes and the Dutch looked at this again. They essentially did a 20-year look back at the risks of physically demanding work and the low birth weight and preterm delivery. Find pretty much the same thing as before. I mean, the odds ratios for preterm delivery with 20 more years of research into it is still about 20%. So is that a high odds ratio? I guess is sort of the question. Does that really make a difference? Are we worried about a 20 to 25% increase in preterm delivery with physically demanding work? In the United States, the whether you want to call it prevalence or incidence, pretty much the same, of preterm delivery is about 10 to 11%. It goes up for specific ethnic and racial minorities. So African Americans, it's about 14% or something like that. So 20% increased odds ratio, if you think about that distributed over the population, that's, you could cut that down by, 2 percentage points theoretically. We'll get into all the other things that need controlling and all the other causes of preterm delivery. But, small odds ratios splayed out across a large population amount to decent preventive activity there. So that's why we end up concerned about that there. But all this to say is that sort of the estimated risk of physically demanding work and pregnancy really hasn't changed. So there was the initial look in 2000, which was about 15 years, pile another 20 years of research onto that, and it's still about the same. So it's for real. This is stuff we did in Connecticut. We took the entire birth registry for a year, and they all had, this was my heroic assistant, they all had text coding of occupation and industry. So we coded 40,000 text lines in for industry. This preceded the NIOX automatic coding of text lines here, and compared low birth weight by the occupational group that we had, using secretarial workers as the referent group, who had an absolutely sort of spot on, right at the average birth weight experience there. So food prep and serving workers, so these are the real grunts of the restaurant business, the dishwashers, the bus people, anybody who's lugging the delivery people and carrying, stocking, shelving, and the like, had about a threefold odds compared to secretaries of low birth weight, which was really quite substantial there. The other people whom we found had this increased risk and hadn't really been seen before were material recording, distributing, and handling. That's a fancy word for the UPS and the Postal Service delivery people there. And so right away, they're lugging hard loads. Personal appearance, retail sales workers, fundamentally on their feet a lot there. The personal appearance also includes beauticians, and there may be some concerns about chemical exposures within that there, although that's more likely not to cause low birth weight as much as it is to, be potentially teratogenic. And, here we adjusted for all the usuals. And so this is exclusive or controlled for smoking in particular there. So we did find that. And again, there's not a lot of industry in the sense of high exposure, toxigenic industries any longer here. Connecticut had a very large service economy even at this point there, and we came up with exposure groups whose exposures are primarily physically labor and handling there. These are just some other corroborative ones. This was a meta-analysis, a whole mess of small studies. As you can see, the ends are only in the sort of 30s to 50s range. But looking at maternal occupation in the food industry, and they all came up with risks for preterm delivery, separate again from low birth weight, and the two of them oftentimes have different antecedent causes. Looking at that and finding a risk of about 1.5 to 1.6, so very significant. I don't have the sort of formative number, but you can sort of eyeball that it's hitting around the 1.5 range. Increased risks in patient handling. So these are the Danes again. So you have the national birth cohort. So, you kind of envy their numbers there. They can get 60,000 live births in Denmark. And look at person lifting. So this mainly occurred with nurses there. So person lifting being the sort of grunt work that nurses do, and what they found, although the individual odds ratios aren't significant even when controlling, is that there's this very obvious gradient that goes on upward from the amount you're lifting every day, from very small or almost no lifting to just constantly lifting, repositioning, assisting patients, catching them when they're falling, keeping them from falling, and the like. So lifting is really becomes probably one of the really major occupational hazards in pregnancy now, more so than toxicants and other chemical type exposures, except in particular instances. Most people have seen the NIOSH lifting equation, and I won't go into excruciating detail into the NIOSH lifting equation, but NIOSH wanted to design some clinical guidelines for occupational lifting in pregnancy, and one of the problems is that the studies aren't particularly good at quantifying how much lifting people are doing outside of those sort of broad areas that you remember from the previous slide, where they may be lifting 1,000 kilograms per day. So what they did instead was to take the NIOSH lifting equation and apply it to healthy lifting, not necessarily that would be injurious to the pregnancy, but would be injurious to your musculoskeletal system, particularly your back. And in particular, what they did, let me see if I can find the pointer here. What they did was to take this horizontal multiplier as the main source of increased exposure to lifting hazards. The rest of them are lifting off the ground, lifting from hip size, vertical, time related, et cetera, But what they did was to construct these safe lifting recommendations based on the fact that the gravid uterus was going to begin to sort of shift on anteriorly and expose workers to an increase in this horizontal multiplier. So they use these again, as I mentioned, these are biomedical or biomechanical considerations rather than based on the epi of reproductive hazards. And what they came up with is this. They published it in the American Journal of Obstetrics and Gynecology about 10 years ago. And essentially kind of a flow chart that I have to, sorry, my site fails there. Essentially a decrease in a gravid uterus. So these are less than 20 weeks gestation and 20 weeks or more here and here. And finding that using some of the vertical multiplier there is that they essentially don't want you lifting off the floor, but then the recommendations as this horizontal multiplier increases start to go down. But from about less than 20 weeks gestation, where you could reasonably lift 30 pounds within the safe zone, if you will, of the vertical multiplier, that drops down to about 22 pounds. And if you're lifting for more than an hour a day, that drops down from 18 to about 13 pounds, and really minimal exposures to lifting, no more than about 10 pounds above and below. So good guidelines for that. There hadn't been any previous guidelines prior to this other than a 1980s recommendation from the AMA, which was just expert opinion based, to say that lifting, the first half of pregnancy you could lift 50 pounds, and in the second half of pregnancy you should limit it to 30 pounds, and that with no evidence base following. All right, so I'm going to look at some clinical assessments there. The problem is that people come to you when they're pregnant and not before they're pregnant, and the ideal thing would be to see a workplace and control the exposures, or think about the exposures before they become pregnant or before they want to conceive. So in the case of men, for example, you're going to want to check lead level because it's associated with oligospermia, azoospermia, poor morphology, male infertility there. So I tend to sort of focus on pregnancy because that's been my sort of dead horse to flog. But what you want to do is try to control the exposure before pregnancy. It's very hard for people to get leave or transfers if they say, I'm considering reproducing, but I don't know when that's going to happen. And so put in for a transfer, you don't want to burn up your FMLA leave, you don't want to burn up your sick leave there. So the ideal is to try to control the workspace rather than have to chase after the worker. If people are working with lead, it's ideal to check blood lead and reduce their exposure. Think about vaccines, particularly teratogenic ones like rubella, and then biomarkers. If you have them, if they work in X-ray, they should have film badges, and you can go back through their history. And a good run of negative exposure film badges tells you that the exposure controls, whether it's personal protective equipment or administrative controls or the lead line shield, everything to that tells you that they should not necessarily have a problem. All right, and so generally we tend to sort of, as I mentioned before, is that advice occurs after conception. And so you have to give people the best appraisal. And then the other thing to remember is that for things like lead, people are oftentimes, the action level for lead has steadily gone down. And even now in the past, generally recommending that people not conceive unless they have a lead level below 10, and we've probably shifted that down to 5 now. But what do you do if people are sort of hanging around at 10 or 12 there, and they want the pregnancy, it's an intended pregnancy, et cetera, is to sort of make sure that the exposure is limited, and make sure the exposure, particularly to things like lead, which are going to be an exposure postnatally in the household, are controlled afterwards there. And then exposure control and early childhood stimulation can actually obviate and reduce many of these. So studies of middling to high maternal lead levels have found that sort of early childhood education stimulation, actually the outcomes were no different than non-lead exposed kids at 5 years old. So you can make a difference even postnatally there. And we'll get onto this there again. So what you tend to get when people do pregnancy assessments, and obstetricians have a lot to worry about. They have a ton of things on their mind. They're very busy, very risk averse people. And there's, with every pregnant patient, there's 100 things that they have to be thinking about there. So we're happy to give them advice there, because in general the request comes as say, oh, my job has chemicals, so they write on a prescription pad or a letterhead to say avoid all chemicals. And I'll show you the workplace doesn't really know what to do with that there, and so it can be very deleterious to the pregnant woman. You know, pay and benefits get affected. You might get laid off. You might think, even if you don't get laid off, it's, well, you're not really serious about this job, so you get on sort of the second sidetrack there. And until recently, it wasn't covered under the ADA. Why? Because it's not a permanent disability. It's temporary, time limited, and considered a normal function of life. And so many pregnant individuals weren't until recently, and I'll show you that because that goes to the heart of the Pregnant Workers Disability Act, to give them guidance. So what you want to do is sort of look at exposure. So let's take, I've got a couple of nice cases to show with, we can look at some pictures there. In Connecticut, we used to actually get paid to go out and see people's workplaces there if they were pregnant there. So you got a veterinarian comes to us there and said, I just got pregnant, what do I do? And so what's a vet's exposure? So here's our vet, and so A number one, right, is x-rays there. So how do you x-ray a Great Dane? You don't sort of put them on the table and say, take a deep breath and, you know, hold it and I'll go around the corner and snap the picture, right? It's not a human who you've got control. So what do they do? How do you do that? And it's usually sort of a combination chest and KUB on that table, right? So how is it done?
You have to, you know, sort of.
Yeah. So two people, one holds the front paws and one holds the hind legs, and they stretch it out on the table, and somebody hits a foot switch when the Great Dane is properly positioned, right? So that's a bit different than your dentist or the people doing chest x-rays here, right? It's, you know, it's stretched out here. So she's got essentially sort of the full complement of lead. And so, you know, for our purposes here, a wraparound shield. So this is covering the uterus, ovaries, reproductive organs, et cetera, et cetera. So one solution there is and she had a film badge too, to look at. But so one solution here is immense personal protective equipment. The other solution is to have somebody, if you have techs, if you have a large enough vet, is to have another vet or some of the techs do it there who aren't, and still keep the personal protective equipment. So big hazard, all right? Typical client, right? Okay. So hazard, come on, nobody's come up with a big worry of infectious disease. Toxo, right? Yeah. So toxo is very teratogenic if the mother's not immune or exposed. So most vets, you tend to think, most vets grow up with animals, right? And they, you know, there's 3 dogs and 6 cats and a couple of rabbits. And so they're generally, you think they're going to be exposed to toxo, and most of them, by the time that, you know, then they go to high school working with animals, they have to work with animals in college because that's how you get into vet school, and then you generally do the work in vet school there. So most of them have positive toxo titers. We saw 2 in a row who had negative toxo titers as sort of full-fledged doctoral veterinarians, and so we had to be very careful with them there. And in this case, it means, you know, really avoiding the fecal material and urine in particular for cats there, and somebody else cleaning out their boxes there. But it surprised us there because you generally sort of assume that many are immune to toxo. Any idea what this thing is? Have anybody worked? It's anesthesia equipment, AKA a knockdown box, right? Because you don't start an IV and then give them midazolam or propofol or something like that. You can't do it, right? So your recalcitrant cat gets dropped in the box, the cover placed on, and the gas turned on there, and so until they go to sleep, then you can remove them from the box and take that. So problems with that, obviously, waste or stray anesthetic gases there. Now, most of what they use are halogenated anesthetics, so halothane and fluorine and the like, and they don't use nitrous for animals there. So, and we're scavenging systems kind of built into the wall for this there. So this made up a closed system, but it was still, we had checked the ventilation, checked the scavenging system, reduce their main sort of operative materials there. It becomes a closed system. If you're doing lung surgery, you generally knock them down and then intubate them while they're still down. So then it becomes a closed system, much the same as an intubated patient here in the ED there. So here's sort of a list of our VEDS hazards. So you've got exirradiation, protection from that. Lifting and strenuous work, you generally have to have somebody else doing that. You know, lifting cats and small dogs isn't necessarily a problem, but if you're lifting St. Bernards, it might become another story. Anesthetic gases, sterilants, they mentioned allergens too, so formaldehyde, glutaraldehyde is a big sterilant, much the same as it is in human work there. Biological hazards, toxo. There's no real data on the live virus vaccines, unfortunately, so it's not really clear what the potential teratogens are. Most of them are for things like canine distemper, which is a relative of measles, but it's not transmissible to humans, so but it's really not clear. Toxo is sort of the big one. As Raphael mentioned, brucellosis in the case of large animal vets. Any idea what this person does? She really looked the part, I have to say.
Mortician.
Yeah, she's a mortician, undertaker, and embalmer. So where's her hazards? Essentially, chemical hazards. Formaldehyde and phenol is actually, we always call it formaldehyde, but it's actually formaldehyde mixed in phenol there. So she came to us wanting to get pregnant and chemical hazards, so we had a look around her workplace there. And so chemicals, essentially, used as embalming, and as you say, it's formaldehyde, phenol, and a few other things, ethyl alcohol, like there. Tissue builder for reconstruction, so this is smaller work that you might do, particularly with reconstructing faces and things like that. They actually had a good ventilation system and sort of ventilated out to the street area here. And you can sort of see that. So here's kind of the story. stuff you never knew about until you go and see those here. So when you embalm somebody who's died a natural death and hasn't been autopsied here, which this thing here is essentially the same as a cardiac pump, it's just missing the oxygenator because you don't really need it any longer. And so what you do is you fill this up with the embalming fluid, and these two tubes cannulate large veins and arteries. So you cannulate generally the femoral artery and the femoral vein and turn on the pump, and it essentially pumps out all the blood and replaces it with the embalming fluid. So it's actually a closed system. And so what we found was between the closed system and the ventilation was that there was sort of just very light fugitive emissions from all of this here and there. And so as long as you sort of guarded against a spill, but we also had good ventilation in here, we told her it was okay. The one thing was that, so there's one set of corpses, if you will, which you wasn't able to work with, and those are autopsied, because what happens in an autopsy?
No.
Yeah, they open it up, right? Yeah, and so everything is disconnected, right? The heart comes out, the lungs come out. You know, you're severed at the aorta, severed the pulmonary arteries. You know, severed the great vessels in the chest and that kind of thing. And then what do they do afterwards? They sort of put it in a bag, throw it back in the chest abdominal cavity and stitch it all up there. So there's no closed system anymore. So they killed that. So the few cases that were either ME's cases or autopsy cases, which aren't very many, you know, for all the reasons that autopsies are not being done any longer, there were very few of them there. So almost everybody she took care of could have been taken care of in a closed system rather than the open system. And so the way they do an autopsy case is essentially to pour it in the open, reopen the chest and abdominal cavity, pour it in and sort of slosh it around and be crude about it there. And so we limited her from doing that because the exposures were much, much higher, but those were sort of few and far between. All right, so last 15, 20 minutes or so, we'll talk about some of the legal protections for pregnant employees. And remember that I mentioned a few slides back that the care which you take in getting an occupational history and history of exposures and list of exposures and list of your job tasks becomes important and not just write no chemicals there. So this was published about 10 years ago in Obstetrics and Gynecology, a group in obstetrics in San Francisco with the title, "My Obstetrician Got Me Fired." So they would write, you know, cannot work with chemicals, cannot lift, cannot do whatever, you know, just sort of based on what they had there. And so because this is the United States and the job protections aren't necessarily adequate, or the options that you have of losing your job may not be, they don't necessarily have to replace you. And remember that these weren't protections in under the ADA either. So the point is that this came out of the New York Times based on this article, which is that oftentimes the notes for pregnant employees backfire. And so you have to go off work at mid-pregnancy, use up all your sick time, FMLA leave, et cetera, which then leaves you zero time or very marginal amount of time for postpartum, postnatal leave. So, you know, what we're trying to do around for this. So, someone you all know and love named Candace Tanis and Liz Milbank, who was a PrevMed resident a couple of years ago, did these under the NIOSH pilot project thing, which was to sort of go out amongst the, what we did was hang around in the ultrasound, in the neonatal ultrasound rooms in two of the Sinai clinics and hospitals, and ask people what their job was, what their perception of their harm from work, whether or not they needed a job change, and whether or not they had requested a job change, and then ask them about their provider. And in about many cases, so all participants, the provider asked about the work in about 50% of them, and only about a third did they counsel on high-risk activities. And for all participants, they only gave 12% a work restriction note, but even in the people who either reported that they thought their job was harmful, they felt they needed a job change or requested a job change, was only about a quarter of those people were given a work restriction note. Same figures for job duty change, and even lower figures for the OBGYN suggesting an accommodation. And so much the same here. We took sort of found that people who reported previous pregnancy comorbidities were more likely to get a restriction note, and someone who had had a previous pregnancy in which there was earlier preterm labor were about twice as likely to get a work restriction note or to be counseled on those work-related activities. And interestingly enough, this was more likely to happen. This sort of surprised us here, was that African American women who were seeing the OBGYN, they were about 3 to 4 times more likely to have safe work discussed, twice as likely to get a restriction note and to discuss a job duty change. And we still have to sort of follow up on this there to sort of figure out whether it could be a combination of the work that was done and that they mentioned it, or the other surmise, which we have to kind of look at and find another way of going about doing this, was that the obstetricians were more likely to ask because of a sort of a perceived risk of increased preterm labor, particularly, or low birth weight delivery. And we can't really say from what we have already whether or not that's true, although we did adjust these figures, the adjusted figures, which were fundamentally the same as the raw or crude odds ratios, were adjusted for any obstetrical comorbidity. Do they have diabetes, hypertensive disorders, previous preterm labor, and the like. So that sort of surprised us, and that's sort of grist for the mill for the next time around there. And this is my great slide about risk assessment here, which is that you have to be the one taking the history, and you can't sort of just sort of go and surmise that because they say they're worried about X is that you didn't ask about A, B, and C. So we're the ones who always know the risks of the job there. And so if the problem is they say is jackhammers, you want to say, that's great. What else might you be exposed to there, and how may that be problematic for you there? So in my case, I think this is socially patterned because it's coming from Southern Virginia, and I'm not really quite sure anyone asked about it. So let's talk about legal protections. And so this is sort of I like to run through the cases, partly because it's an individual case that makes it real, and then you can sort of see where the Pregnant Workers Fairness Act comes from there. So Ms. Young was an air driver for UPS. She essentially went out to JFK every, early in the morning and got all the, what are mostly legal documents. And how much do those weigh? They weigh about half a pound. They're those sort of letter things that have to be overnighted to law firms and the like there. But there's boxes, there's stuff that people ordered from Amazon and that comes in on it there. And so the air driver job requires that you be able and capable and required to lift up to 70 pounds and to pull or 70 pounds. But this didn't happen very much, particularly in the job that she was doing, which was airport to downtown, very much mostly. So she'd been infertile and she got a leave of absence and got IVF, and her IVF was successful. So about a couple months into the pregnancy, she requested a 20-pound lifting limit for her work when she was pregnant. UPS turned her down. They said, we offer light duty for 3 groups of individuals. We got people who have on-the-job injuries, so work-related injuries that there's rehabilitative work to. We can offer that too there. We offer them for people who are accommodated under the ADA, so you've got a persistent disc or radiculopathy, and you've got a disability in that. And for people who had lost their commercial driver's license certification for whatever reason, hypertension, diabetes, the whole sort of gamut of reasons people might lose their CDL certification. They said, we offer light duty for those 3, and you're not one of them. Pregnancy is not one of them, so you have to go on leave of absence if you if your obstetrician says you can't lift that much or you don't want to lift that much. So she went on unpaid leave of absence and lost her medical coverage as a consequence for that there. So here are the legal, just sort of, this is what the courts were working under at the time for legal cases, is the Pregnancy Discrimination Act. And what that really is an amendment to the 1964 Civil Rights Act that includes pregnant workers, covers employers, more than 15 workers. And the fundamentals are that you can't single out a pregnancy-related condition for ability to work. It may require you to submit a doctor's statement before granting leave or sick pay. If they're temporarily unable to perform the job, they must treat her the same as any other temporarily disabled employee. They must be permitted to work as long as they're able to perform their jobs. And if there's an employee on sick or disability leave, whatever your time period for rehire, 3 months or 6 months or what have you, you have to hold open a job for that. So that's sort of the Pregnancy Discrimination Act from the 70s in a nutshell. The problem is that the enforcement arm was under Department of Justice, and you had to go and sue under federal law to be able to obtain those if you were discriminated against, and there wasn't very much mechanism. This is just a little bit of a sidebar. This is pre-ADA, right? And so job qualifications. So an ad in the precursor to the JOEM, which was the JOM, was selling essentially pregnancy test kits for people's pre-employment physicals at that time there. And the copy on it's really priceless, and it's hard to sort of read there, but I like it. It says, find the pregnant before your company gets involved in costly training programs as well as health and sick pay coverage. So anyway, this is in our lifetime. So anyway, the district court actually ruled in favor of UPS. They said, okay, pregnancy is not one of those disabilities. Sorry, Ms. Young, you're out of luck. That the circuit court upheld and ruled that limiting those modified light duties was, quote, pregnancy blind, although it didn't mention pregnancy one way or the other. The argument on Ms. Young's side was that she was in a 20-pound lifting limit. She was similar to all those other employees, particularly the work injured or the people who had ADA accommodations, in being able or unable to do the specific tasks of the job there. So the Supreme Court essentially ruled in favor. They didn't say you won. What they did was they sent it back to the lower court to say you have to comply with you have to read the Pregnancy Disability Act, and because the employer provided accommodations for other people but did not mention pregnancy one way or the other, she was entitled to argue before the lower court that she was substantially limited just the same as those other 3 sets of people. And at this point, UPS saw they wouldn't win, so they gave up on it there. It never did go back to the lower court. So essentially, Ms. Young won her case. So that's what's kind of led us to the Pregnant Worker Fairness Act there. And so what this is doing, or the way to sort of think about it there, is that it's an extension of the Americans with Disability Act and the ADA Amendments Act to pregnancy, even though 2 things happen. One is that pregnancy in broad brush general terms is a normal human health condition, but that there are restrictions or inabilities of people to do some certain things in pregnancy, and that sort of depends. Like lifting heavy loads is generally a bad idea, as we sort of saw from the EPI information on it there. Forgot where I was going with that there, but that there are conditions, so back pain, right? The SI joints and the back joints start to weaken as a consequence of progesterone, so you're more likely to hurt your back or you walk around with back pain. You may be hypertensive, you may be swelling, you may be unable to lift because of that horizontal thing there. So it fits into the ADA with the understanding that it's not a permanent condition, is that it's temporary, but they have to be accommodated, and the employer has to provide reasonable accommodations related to pregnancy and childbirth with the same language as the ADA, unless it'll produce cause the employer an undue hardship there. And the House committee that reported out on the bill, I won't read them all to you there, play PowerPoint karaoke, but things like drinking water appropriately sized or changed uniforms, break times to use the bathroom, lifting and strenuous activities come under most of those there. And so they gave some examples of what that was possible. Covered employers can't require the employee to accept an accommodation, and all the other things that generally sort of go under the ADA and the ADA amendments. They can't retaliate, they can't require you to take leave if there's another reasonable accommodation that they can make. So that kind of covers the current law there. And so a lot of uncertainty is sort of the basic line here. There's sort of twofold things. Most women work through the pregnancy up until term, and the point is to sort of keep things helpful and healthy for them there. Some people, as with any other disorder that we see in occupational medicine, people want to be excused from inconvenient things that may or may not necessarily be harmful, and you have to be clear about that. You have to be clear about the degree of uncertainty that we're working with. You have to be clear about the fact that there's lots of other factors that go into adverse pregnancy outcomes. So, for example, we don't necessarily know a lot about miscarriage, spontaneous abortion, because there's a 15 to 20% incidence of that there, most of which is unknown or genetic. With workplace employers, what you want to think about is how hazards can be controlled for all workers, how you can keep workers safe and employed at the same time, because the work and the benefits become important to them. They're clearly important, particularly in the United States, where still leave becomes problematic, and be prepared to advocate. So that kind of does it.